With that, I'd like to give it back to Tony. Thank you very much.
Thank you, Ruzi, and I think that sets the scene very nicely for us with some of these fantastic tools that are going to make life easier for all of us in hip arthroscopy. So thank you for that. I think we're at the stage where our giants of hip arthroscopy are going into the virtual room. And so whilst we wait for them to join us on this platform, just want to emphasize the fact that this sort of technology is really useful in terms of training. So for all of those of you who are with us today, who are trainees and are trying to master the skills of hip arthroscopy, this technology would really help you with that. And as you saw in Dr. Gold's presentation, it's something that can help you achieve your sort of competence with certain activities before you then go into the live environment with patients. So do please try and embrace this technology. It's very helpful for your development as a surgeon. And I think even for the more senior surgeons, it also gives us an opportunity to go into this virtual environment, and we can then develop other skills as well. And you'll see a little bit later when we are in that virtual room, you'll see some of our giants of hip arthroscopy today and how they interact and how they can use this technology to share their experiences. We have Dr. Laskowski and Dr. Okiai as our sort of faculty who will be doing the operating, and then Dr. Lau will be in there as well as one of our guests, and so we'll be able to see them interact and discuss how each of them may be doing things slightly differently. And also in the room will be Dr. Kakic and Dr. Eliza Laturi. Now, you won't be able to see them as avatars, but they will be in the room, so you'll hear their voices and they will contribute to the discussion as we go through the procedure. We're just about to connect you into the virtual operating room.
Everybody can see here, so I'm standing beside Jovan. Team surgeon is Dr. Ochiai, and you can see Chuck on my right here as well. So different parts of the world all congregate in the same area.
So if we take a look here, you can actually grab this femur and rotate it. And one of the really neat things about this is this can give you a really nice three-dimensional understanding of where that cam lesion is. So typically between medial and lateral synovial folds, you'll see this little area that's raised up. Derek, if you'd like to grab it and kind of take a look at it, you can rotate it.
Yeah. So, I mean, it's great that you can see it three-dimensionally. I think that from a teaching standpoint, this is, really good to get like this, because when we're looking in arthroscopically, we're having a 2D view and we're trying to move the camera to change the position to try to get a sense of the three-dimensional aspect of it, but it's not like this.
Yeah, Chuck, what do you think? Pretty impressive to see that raised area, and really gives you a nice understanding in 3 dimensions where that cam typically lies.
Yes, I would just put a little bit more to the front. I think that most of the cam we're dealing with the cams more anteriorly as well, not only laterally. I don't know what the other guys think. It's a nice, impressive position, and the model is phenomenal. I must be honest. It's really okay.
Hey guys, we were just saying before you joined us in the room that it would be great to be able to do this with real patients, to pull out the femur and be able to appreciate the cam shape this well.
Well,
yeah, go ahead, Derek, I'm sorry.
I mean, every cam is different. I think Dr. Bird once said it, every cam lesion is like a fingerprint. No two are exactly alike. So I would agree that this one is certainly more lateral than you typically see. But as this technology changes, I can see having like different cam lesions and approaching it differently. And this is the kind of the start of trying to merge virtual reality and arthroscopic surgery.
We can see the fluoroscope here coming in between the legs. Some people have it from the opposite side of the table, and then you can have your arthroscopy stack and your screen somewhere where it will be easy for you to see what's going on. We can see here that we've got the fluoroscopy screen as well, just to the bottom of, there you go, sort of off to the left there. And so guys, do you want to demonstrate the sort of putting on the traction and taking fluoro shots as we've got that there?
Yeah, Tony, it's amazing how many different ways you can really set this up. But you can see this actually allows us, you can move the arthroscopy monitor around, you can really move the C-arm around. And I do it a little bit differently. I bring the C-arm in from across the table. And what you can notice is what's neat about this is you can get an AP and a lateral at the same time. And again, that's kind of the power of the VR world. And so you can see we've got a nice AP. We can kind of see the overall contour of what the acetobifemoral joint looks like. And so I think it'll let us essentially be able to take x-rays whenever we want and really assess. So again, another advantage, 3D spatial orientation is difficult, triangulation is difficult. So if you look, we can't do this in real life, but you can actually pull out the entire acetabulum, pelvis, and femur all at the same time and assess, and you can move this around and give yourself an idea of, okay, what is my ideal trajectory for an anterior lateral portal? Where should I make my incision to make my mid-anterior portal? So it really gives you an advantage in terms of that kind of muscle memory and repetition to be able to do this. And this is something that I think is, again, really fascinating. Like we talked about with 3D printing, just imagine how limitless this can be in terms of a training tool. Yeah, Chuck, any pearls for us?
I'm doing exactly what was said now. I don't think so that there's anything more to say. This is just phenomenal that you can actually visualize in a virtual space what you're imagining in front of the patient. And I think that is, for teaching point of view, this is absolutely amazing. It's an in-step between being a beginner and going on a cadaver and eventually dealing with a real patient. That is, I'm very
really an incredible teaching tool.
Jovan, also, I think just one little tidbit. I think this is nice to get the trainee to understand where they'll be standing next to the patient. You don't get that often enough before you get into the operating room. So right here, just spatial orientation of where you should be standing height level for the bed itself, and the distance you'll need from your arm extension is very important. So this is a very, very nice tool to set yourself up for success.
Yeah, AJ, I think that's an excellent point. And you can actually see, I can adjust the table height. I'm a shorter surgeon, I'm 5'10", and I like the patient to be basically where my arms would be at a 90-degree bend. So that way I'm using fine motor muscles and not activating my deltoids and my traps to operate. So everything's kind of tight. And like you said, orientation, where you're standing, where your assistant's going to be, it's a phenomenal tool in terms of being able to use this.
Yeah. Well, Jovan, to that point, I'm a smaller surgeon too, but I usually have the C-arm up more, and the reason is because I have the non-operative leg abducted like maximally. So it's almost like they're doing a split on their non-operative leg, and then I bring the C-arm very close to parallel to that leg, because then I can rotate the C-arm, and instead of having like this dual view of the acetabulum where the whole pelvis gets in the way, you can really get just views of the anterior acetabulum as well as 0, 30, 60, 90 views of the femoral side. So you can get a sense of both anterior pincer impingement and anterior cam impingement.
Sure. So I'll show you kind of how I like to do my traction. I like to adduct the leg just about 5 degrees past neutral, and you'll see what we'll do is kind of apply traction here. And we actually have a traction timer there on the screen, and we can essentially monitor how long our traction time is. So we'll take an x-ray here. So what do you think, Chuck? Do you think we have adequate distraction there? Is it too much, too little?
I think this patient has a micro instability.
I would say so. And is now we're going to get access with our needle. So guys, really, really interesting that you can actually hold the needle, and it's so immersive, it feels like it's in your hand. And all I'm doing is holding the trigger down. And one of the pearls that I like to do is this module, we're gonna go peripheral compartment first. I'm gonna lay the needle on top of the leg and I'm gonna take an X-ray. And you can see what we're trying to do is localize this in almost a Dean's portal fashion to get to that cam lesion. And so you'll see me kind of back the needle out. And this takes a little bit of kind of fidgeting with it. And like Chuck said, you'll see I'm trying to hold this parallel to the floor. And I can actually feel I hit capsule there. So what I'm going to do is take an X-ray, and you can see I'm hitting the greater trochanter. And so I want to make an adjustment, and I'm going to slightly change my position and slightly change my angle, and we're going to head back in. And we could feel, I felt the pop, I felt the controller buzz, and we're going to take a look. And sure enough, you can see we hit the base of that cam lesion, right at the base of it. And we're going to, like I said, go peripheral compartment first with this. And Derek, what thoughts do you have about going peripheral first versus central? How do you like to do this on a day-to-day basis?
Well, I really like to go central compartment first, do a diagnostic, do anything with the labrum if I'm going to do a reconstruction or a pincer, and then go into the peripheral compartment, do the cam, then go back. So I like to do it that way, but there are some non-distractible hips that you have to go peripheral compartment first, or extracapsular, and then do a capsulotomy first to able to get access to the central compartment.
AJ, any thoughts? Peripheral first, yes. Central first?
Central first, typically, but just like Derek mentioned, peripheral first on those overcovered hips. I like the inside outside in sort of technique. Put the needle in just like we just did, develop that, have the scope in, and then make your capsulotomy under direct visualization, making sure not to injure the articular cartilage, or in peripheral first, the labrum itself with your beaver blade.
Good question for everyone here is cannulas versus cannula-less. Are we using La Pistola that Victor made for us? Are we going cannulas? What are the going thoughts within this group about using cannulas to be able to do this?
Well, I'll start. I'm typically not been a big fan of cannulas, mainly because when a lot of us started doing hip arthroscopy, there was no instruments that were long enough to fit through a cannula that would fit inside the hip. So if I had to use shoulder instruments to do a labral repair, it really didn't matter whether I had a cannula that fit into the hip because I couldn't fit my instruments down it. So I got pretty good at using Dr. Lizatori's slotted cannula. And then I got used to the fact that there's so much freedom without a cannula. Now, this is totally different because you can tie this easy switch in a knot. It is so flexible that it's almost like you're operating naked.
Yeah, Chuck, any thoughts about cannulas versus no cannulas?
From the beginning, I was always using a cannulas. And I'm using non-disposable cannulas purely because of the economical reasons of medical schemes and insurances. And in the situations of when reconstruction is necessary, or if it's any other complicated procedure, then I do use cannulas, and I'm using the easy switch as well. Unfortunately, this is in the process of approval by the medical schemes. But the other reason why I'm using cannulas, I'm a 3-portal surgeon, and one of my portal is basically fluid access portal. And my metal cannula is allowing me to have a control of the fluid, or flow of the fluid, so that it doesn't get absorbed unnecessarily through the tissue. It gets controlled throughout the surgery, and I like my fluid on the floor, not in the thigh.
Very, very good point. AJ, Victor?
I think that you do need to use cannulas when you're doing suture management. That is probably the only step for me that is mandatory to go through a cannula. Most of the time, I just use the slotted cannula, and I like the freedom of the instrument within the portal without the restriction of a cannula. Saying that this new generation of cannulas are just like Derek said, it's like operating naked, almost like the feel of having nothing within the portal. But again, I think that if you're doing suture management, cannulas are mandatory.
There you go.
So let's talk about the view that you guys like for your cam decompression. So this would probably be my preferred view. I tried it. I move the scope around a lot. I change the angle quite a bit, and I move around quite a bit. But I like to try and get what my C-arm image is going to be for a done view.
So, I mean, that's a pretty good view there to start too. And then you can certainly just rotate, taking advantage of the 70-degree scope to get a full, kind of more of a sense of the three-dimensional nature of it. I know a lot of people use 30 degrees in the peripheral compartment. I really like the 70 degrees, so I just stay with that.
Yeah, Chuck, 30 or 70 in the peripheral compartment?
I like panoramic view comparatively, and I always use in periphery. The 30 degrees gives me more broader view of the femoral neck, and I prefer 30 degrees. And from the portal point of view, what I do, I kind of having a triangulation that would be superior, and then I have another one inferior. And most of the time, I like here the anterolateral portal is my camera portal, the superior portal and the inferior portals are my working portals, and I'm changing views among those three. It depends what I want to see, especially when I wanted to assess visually amount of work that I have done.
Yeah, Victor, let me throw it to you. What about capsular closure? Are you leaving the capsule open? Are you closing it? Are you placating it in certain situations? What are your kind of thoughts about capsular management at the end of the case?
Well, the main thing that I'm doing now, and for a number of years now, is not to cut through the iliofemoral ligament. So I basically do two separate capsulotomies, never join them together. The lateral one allows you to go more posteriorly before you get into ischiofemoral ligament. And that is like my main window when I go into a lateral cam. You can flex up without traction and internally or externally rotate depending on the shape of the cam and go through that hole.
That's great, Victor. Thank you. Now, guys, can I ask you all to move back into the Zoom compartment now so that we can carry on the discussion there? So thank you all for being in there. So Jovan, if we can move you back into Zoom. So come out of the virtual room and then we can continue the discussion in the Zoom compartment. So as we have our sort of faculty and guests coming out of the virtual room, we can actually, Victor, if I can start with you whilst the other guys are joining us. What did you think about this particular technology? And when you were in the virtual OR, how realistic do you think it was? And how much do you think this is going to contribute to the training of our younger surgeons?
I believe it's awesome. The way that you can take out the bone, and Chuck made a comment on the position of the cam lesion that we had there in that bone. They can put the cam lesion to whatever shape or position you want. So basically what we said yesterday in the call, if you can dream it, they can do it.
Chuck, I think you wanted to say something.
I was thinking last night before this meeting, and when we had a dry run and we were talking about it, and I spoke to one of my colleagues who is gynecologist, and he went with not saying this is unique, but also for the training program for their registrars. There's one fear that we as a surgeon mustn't forget, and that all of those toys that we have, doesn't matter what it is, allows us to have a mistake and go again, and have a mistake and go again. The problem is when you get into that way of thinking, that message mustn't come to theater. In theater, there's no space for mistake. You can't come back and repeat it. We have to make sure that we never forget that this is a learning experience. But once when the juniors come to the real life, there is no mistakes, or mistakes has to be a minimal. And that is call me all fart, but that is a big mistake between the virtual and reality. And we mustn't cross that line.
No, you're right, Chuck. And Ajay, you're going to say something.
I'll just go one step further. In my fellowship down in Birmingham, Alabama, there was always a kind of motto that the OR is not a place for thinking. It's a place for doing. And that's followed me through my subsequent fellowships and even into practice. You know, every step should be thought out and memorized and perfected before you get into the OR. Really just executing the tasks. There's really not a time for, you know, what am I going to do here? I mean, of course, there's some nuances for the case at hand, but it really is a place for completing the tasks that you know you want to do perfectly every time.
And AJ, if I could second that, you know, we call it the flight plan. So whenever I have a resident on my service, they get a very long, very HIPAA compliant text message about each case, what the plan is, how we're going to execute it. And it's rare for us to deviate from that flight plan. And I love this tech because as Chuck and you pointed out, the OR is not, there's no room for mistakes. So developing simple things like triangulation, you know, my third-year residents or fourth-year residents, it'll take them 10 or 15 minutes to establish an anterior lateral portal. And if you're burning that amount of time under traction, that can't make for you know, a good experience for the patient. And so having this tool where they can practice at home and work on triangulation skills and get that immersiveness, I think is really, really powerful.
Well, I think the other thing is that this can score you. So this is eventually, this is a way that we're going to be able to assess, is somebody ready to come into the operating room? Like, how good are they virtually first before they come in?
Oh, exactly. And, you know, Derek, I think you're almost sort of in an antechamber to the OR, and, you know, the trainee goes in. If he scores high enough, he goes through the right door. If he doesn't, he goes to the left door, back into the car park and out, you know. That sort of thing.
I believe it's also, besides a great teaching tool, it may also help us with development and research of further techniques for advanced procedures.
No, you're right, Victor. And that's very exciting, isn't it? Because, you know, it really is back to what you were saying, you know, you dream it, you can do it. So there are procedures that we still don't do today that, you know, in 20 years time, we could have dreamt about, done, and helped by this technology along the way.
The environment, really bringing it down to a controlled setting is how it should be in the operating room. But really, it's so immersive, and you really trick your brain into thinking that you're there. You trust your surrounding guardian to protect you, but of course, setting yourself up with your furniture and your wall space is key. But it's really phenomenal, better than I expected. To be honest, my first experience with it, and just really, really thrilled to see kind of where this is going to go. The next iterations. It's just, I can't wait.
But what a way to bring, you know, surgeons together from across borders. What a way to be able to use it as a teaching tool. And I think to Victor's point, the future being limitless, imagine you have a new technique or procedure that you want to try, you know, an allograft augmentation of gluteus medius tendon. You can actually work out those bugs virtually rather than, you know, trial by error or the expense and cost of a cadaver in a cadaver lab. So it really is impressive tech. And, you know, I'm looking forward to Danny iterating in the future and making this thing even better and better.
Yeah, and I mean, Danny, is there a plan to take the virtual reality into sort of an augmented reality setting so that you can practice at home and then bring it into the OR with you?
Yeah, thank you, Tony. So we are working on something that actually brings a patient CT scan directly into VR right now. And it's already got Health Canada clearance, and we're just waiting for our 510K. But there'll be some exciting news coming down the pipe for patient-specific procedures and planning.
That's great. It really is exciting. And Derek, you know, you've played with this technology for a while as well. What thoughts do you have about the, you know, how realistic it is and what the next steps might be?
Well, I think in some ways it's a little bit more challenging than actually doing a hip arthroscopy. So if you're good at VR, you might actually be really good at doing it in surgery too. I think the sky's the limit. You know, I cannot wait for, you know, modules for like labral repair, labral reconstruction, labral augmentation, gluteal repairs, gluteal augmentation. Jovan, hamstring is coming soon, so other people are going to get good at doing endoscopic hamstring repairs too.
Love it.
Well, look, guys, this has been really exciting, and I think we're running out of time very quickly. So I'd like to thank all the participants for joining us today. I'd like to thank our special guests for joining us as well. So Drs. Lau, Kekic, and Liz Laturi. And of course, our faculty of Dr. Laskowski and Dr. Opchi, and special thank you to Danny Goal. And I'd like to hand over to Bruce Carruthers now from ConMed, who will see us out. Thank you all.
Thanks, Tony.
Thank you, Tony.
Yes, I was just going
Thank you, Tony.
Tony, for the moderation there, for all the commentary and coordinating this with the group in the virtual OR. Would love to have seen you with the headset on as well, but you did an amazing job externally, so we needed you to hold down the fort, so thank you for that. And again, just a special thanks to Jovan and Derek. Guys, amazing job as our esteemed faculty here, and Danny, the Precision OS team, you know, from you and Craig and Kevin, John, Kirsty, and Dave, and everyone else on your team behind the scenes. You guys, you know, the partnership we're developing together and what we're going to be able to do in the future, to see the excitement that's being built right now by sessions like this is incredibly motivating, and I get the pleasure of driving this from a ConMed standpoint. And I want to thank our ConMed team, so Carl and Ruzi, Erica, Shane, everyone else behind the scenes, and all the sales team have called in here. Guys, I mean, this is you're going to hear a lot more about what we're going to be doing as we mobilize this technology and really push the frontiers of medical education together. So, and finally, I just want to say to all the attendees, anyone else who tuned in here, a huge thank you. This is it's great to have you on board on a Saturday. Have an amazing rest of the weekend, and thank you so much for tuning in. Thank you.